What's up, guys? Today, I got to sit down with Dr. Agneta Odera. She is the quarterback of one of the most important healthcare projects on the planet today. She is a general surgeon. She is a pediatric surgeon and a pediatric heart surgeon. Forbes magazine says she is a genius, a force of nature, and that she is ushering a new era of healthcare that is female-led and holistic in its approach. Hope you guys enjoy. So you and I were at a lunch last week.
Yeah.
And the context was the dismantling of USAID and the ripple effects that's had across healthcare globally. I have in front of me a press release from December that talks about the United States and Kenya signing a 5-year, $2.5 billion health cooperation deal that's supposed to help basically every area of healthcare across Kenya. Has this been a big deal in Kenya? Are people talking about this? Are they excited about it? Are there concerns about it? Are there questions about it? Or what's going on there?
Yeah, I think there's both excitement and concern over how exactly it will roll out. I think with the announcement of dismantling of USAID, those huge concerns were many programs that were reliant on that support.
Sure.
In terms of supplies, medications, surveillance, and then, payment of employers. There's a lot that was relying on that. And so when it was dismantled, people were concerned that all the great efforts and strides that had been made, especially with regards to infectious disease, because that's really where the focus was,
Okay.
that all that effort would be eroded. And so I think with the excitement just comes with the fear and the concern of how exactly is this going to be rolled out.
Yeah.
And I think it also gives us an opportunity to reflect and think, what exactly are the healthcare needs that we have as a country, and how do we want to invest the monies in trying to address those needs? Because I think, I personally think that, yes, infectious disease is a huge burden. HIV, malaria, tuberculosis, malnutrition is big. But I feel that cancer, trauma, and cardiovascular health are also bigger needs that sort of have taken a backseat but are having devastating consequences to the people of Kenya and in sub-Saharan Africa. Yeah.
I looked up before this the big five deaths across the world for children, the biggest areas. And so you have preterm. Those are kids that are born really premature. About 1 million kids die annually across the globe, sadly. My cousin just had twins that were a couple months early, and they were like 3 pounds or something when they were born. And if they hadn't been born with a very high level labor and delivery unit and then a NICU, PICU, they were in there for a couple of months, and if that wasn't available to them, I don't know if those little guys would have made it. You've got pneumonia, 750,000 kids dying of pneumonia caught early enough, seems like a treatable situation. And then there's birth asphyxia, other labor and delivery issues, over 650,000 kids there. And then malaria and diarrhea being the next two biggest ones with about 500,000 apiece. I know in the malaria and diarrhea, there's been a lot of progress over the last 20 years in those spaces, which is really encouraging. But what I see, and in our world, the heart defect world, congenital heart defects and rheumatic heart disease, there's anywhere from 500,000 to 800,000 kids a year in that space as well. It's hard to get accurate data, as you know. But I see specifically the work that y'all have been doing at Tenwek Hospital in Bomet, Kenya. You just built a brand new $50 million cardiothoracic center. And by the way, that $50 million cardiothoracic center, if it was built here in Houston, the Med Center, would be a $500 million cardiothoracic center. I mean, that thing rivals anything we've got here in Houston. It is so impressive. Hope people will go online and check out. There's a lot of videos and pictures and stuff online, but it's just super impressive. I want to dive into specifically that in a little bit, but the sort of thesis of my statement is I believe that cardiothoracic unit, and correct me if I'm wrong, but it's going to increase quality of care across the whole hospital
Yeah,
system there at
definitely.
Tenwek. Your
Definitely.
nursing gets elevated, your ICU gets elevated, and I believe that cardiothoracic units like that are the long term solution to at least 4 or 5 of these big five killers of kids.
Mm-hmm.
That it's going to help with preterm kids. It's going to help with pneumatic kids. It's going to help labor and delivery. It rises
The bar, yeah.
the whole system, right?
Mm-hmm.
What are your thoughts on that?
Yeah, absolutely agree. I mean, we started the program in 2006 after we did a screening exercise. And what led us to do the screening exercise is there was a constant exhortation from the pediatrician and the medical doctor in the adult ward to say we have so many cases of heart disease. So the biggest killers were HIV, malnutrition, diabetes, hypertension, and the third killer of patients in the hospital was heart disease. And they would do a great job with medications in trying to get them cured, but they would just reach a point where the mechanical obstruction from the valves obstructed or excessive leaking across the valves, or the children with the congenital heart diseases, there was nothing more they could do.
Mm-hmm.
And they would say, can you do something surgical? Actually, one of the other heart diseases that is forgotten are infectious, like tuberculous heart disease
Yes.
and hydatiid. Hydatiid is a worm that's found from infestation
No
from
kidding.
dogs, infecting sheep,
Wow.
goats, and the nomadic community, because of their lifestyle and being in close proximity to the animals, get infected.
Wow.
And so you get that as well.
It's like heartworms.
Yeah, so you get like huge cysts with
Oh
worms
wow.
around the heart. And with tuberculosis, you get a lot of inflammation and scarring, and the heart sac, the pericardial sac that lines the heart, basically becomes like a constricting bed, and so the heart can open up and feel
Oh
well.
wow.
Yeah, and basically the patients die from florid heart failure. So all these were things that we were seeing, and doctors were saying we need to do something more.
Yeah.
And resources in the capital are scarce.
Yeah.
They have heart programs, but they are not robust, and many times the heart lung machine would stop functioning,
Oh
and
no.
so the program shut down. And it would affect the training as well, because the trainees do not get the numbers they need to actually get to PAN, be qualified to
They
start
can't
their
see
own
the
practices.
number
Yeah.
of cases.
Yeah.
Got it.
And so we did a screening exercise and just said, if you have a patient suspected to have a heart problem, either by stethoscope or confirmed by echo, just send them over. So we had 120 patients, and a good number of them truly had structural heart defects.
Mm-hmm.
And out of those 120, only 6 had pure mitral stenosis. So where the mitral valve on the left side that opens up from the upper chamber to the lower chamber is completely scarred and just doesn't open up. And so out of those 6, Dr. Russ White, trained as a thoracic surgeon and was a career missionary surgeon at Tenwek Hospital at the time. When he finished his training, his mentor gave him a gift, and it's what is called a TABS dilator. Now, this is a piece of equipment that's now surgically in the archives. It's in the, it's
It's like the abacus of
yes,
yeah. Okay.
exactly. And he had it somewhere in a box in his house.
Okay.
And there was a visiting surgeon from Rhode Island Brown University, and he was a cardiothoracic surgeon. And he said, if we had this tool, we could be able to do it, because this is a pure obstructive lesion. We could be able to just put it across the valve and crack it open, and we could help them. And he's like, hey, wait a minute, I have something in my shed. So he goes out and gets it, and we sterilize it. And yeah, we did the first case. And
Wow.
it went well. For me as a trainee, then I had just finished my internship.
Okay.
And I was interested in surgical specialties. And so after doing the screening, we get the patient in the room, open up the chest. And it was the first time where I actually truly handled the heart. And it was just, I will never forget the feeling. I think that's when I knew this is what I'm going to do for the rest of my life.
Wow.
And we put it across the valve and crack it open. And because it occupies the whole orifice, the area around the valve, essentially for a couple of minutes, there is no cardiac output.
Right.
The patient literally arrests.
Yeah.
And then we have to get the heart going and pump volume in. But it was just amazing to see that it worked. And we did it for the other 5. So the first 6, that's how we started heart
So y'all
surgery at
were the heart
Tenwek.
and lung machine, huh?
Yeah, yeah.
Wow.
And that was really cool. But it really showed us the burden of disease and what an intervention could do, like how it would change lives. And so we met with a couple of other people, and that's how we started the heart program.
And that was mid 2000s
Yeah,
or
2006.
that was
Yeah.
2006.
And so in 2008, then we were able to procure a heart lung machine through donations from Dr. Fingleton, at Brown University
Wow.
and other well wishers and Vanderbilt Children's Hospital.
Mike Liskey and
Yeah,
those
Mike
guys. Yeah,
Liskey. This
great
is
group.
someone who was with Dr. White in medical school.
Yeah,
And it's just amazing how God brought different people together and
yeah,
put like minds together. And that's how the program started. And yeah, so over the years, we have seen truly cardiac disease is something that's forgotten. A
okay.
lot of efforts are poured into infectious disease, and rightly so, because they're maiming and they kill a lot of children and young adults. But I think rheumatic heart disease and congenital heart disease is a forgotten,
Yeah,
neglected disease in low to middle income countries and especially in sub-Saharan Africa.
yeah.
We have 40 million people who are struggling with rheumatic heart disease.
How many?
40 million.
40 million.
Yeah. And a good
Wow.
number of them will not make it beyond their 15th or 20th birthday.
And for people to understand, rheumatic heart disease is strep throat
Yep.
untreated.
Yep.
So strep throat is something that my kids get twice a year, and they get some amoxicillin or penicillin or whatever, and it's gone in a day or two.
Yeah.
And if you don't have access to health care and your kid's got a sore throat and you're trying to pay the bills and you don't have time to take them to the in rural Kenya, I can imagine it can be challenging. A very large percentage of folks in Kenya live outside the cities.
Exactly.
Isn't
Yeah.
that so?
Yeah.
Access to care is really difficult,
Yeah.
and so the sore throat might go away, but the bacteria, the virus, it lives in and deteriorates the heart valves. That leads to heart surgery later on from something that is a $1 fix
Yeah.
worth of penicillin.
Yeah. I mean, the New York Times had an article in 2018 where they talked about that when a sore throat becomes a death sentence.
Unbelievable.
And seeing the faces of those kids, it's haunting. And
Wow.
that's those haunting faces are what drove us because every day you saw them on the ward and you knew this is from a sore throat, something that could be cured, and they are not going to leave. And when you ask them, what do you want to leave for? It's, I want to be able to walk to school.
Wow.
I want to be able to kick the ball.
Yeah.
I want to be able to help my mom in the farm or carry water from the river. It's the simple things in life that they want to do.
Wow.
Yeah.
And I know there's been a lot of efforts on the prevention side of that, folks that are trying to, I guess, go to the schools and help detect and treat kids.
Yeah. So we're very passionate about prevention. And one of the things we really want to eradicate rheumatic heart disease so that we can focus efforts and resources on dealing with aspects of cardiac disease that we can't control. Congenital diseases are things that children are born with. So if we could eradicate rheumatic heart disease, then we can focus resources on really dealing with the bigger picture things.
Right.
And so we started a screening program. The first time we went to 3 schools just around the Tenwek Hospital area within a 7-kilometer radius. And we had a 14% incidence.
14% of the kids you
Yeah.
screened had rheumatic
Yeah.
heart disease.
Exactly. So
Unbelievable.
about 1 to 2 in 10
Wow,
have
I knew it was big.
undiagnosed,
I had no idea it was that big.
have undiagnosed. They're walking around with already evidence of valve effects. And they could not remember having a sore throat or if they were ever treated for that.
Wow.
Yeah.
And for folks in the US here listening, this was a problem. I need to Google to get the dates, but 100 years ago there was a lot of people here being infected with
yeah?
rheumatic heart disease. I mean,
Yes.
this isn't just a Kenya or an Africa or Latin America type thing. This is something that did impact everybody globally until penicillin, I assume, became
Yeah.
available.
Yeah. It's just awareness of being aware that sore throats can be lethal and taking them seriously, and having access to simple medication.
Yeah.
Yeah.
And the folks are there the screening process? Is it just a swab type test, or is it a blood test, or how do they detect it?
So to detect the sore throat, yes,
Yes.
there is a swab. You get a throat swab,
Okay.
and they look for certain titers um, to the bacteria,
Mm-hmm.
the anti-streptolysin titers, and then also there's actually a criteria that was developed, the major and the minor Jones criteria, to help. So there's certain constellation of symptoms and signs that the doctor, just on physical exam and taking a history from a patient, can be able to elicit. And if you have two of the major criteria or one major and two minor, then it helps you have a high suspicion that the patient may be having rheumatic fever,
Yeah.
from group A beta hemolytic strep infection, and so therefore you treat them. And now the testing is now available, because before the testing wasn't readily
Yeah.
available, but now the throat swabs are readily available, and you can do that.
So, okay, if a kid, say, had the sore throat 3 years ago, and you meet him today, what is the treatment? Is it just shot of penicillin takes it out at that point, or is it too late, or how does that work?
So if a child gives a history of a sore throat,
Mm-hmm.
that was probably consistent with a strep, because not all sore throats are strep
Right.
infections, yeah. But if you have a high index of suspicion, what we do is a surveillance limited view echocardiography,
Okay.
so that you look for any evidence of scarring.
Okay.
And if there is evidence of scarring, early scarring, or if from history they had certain characteristics. So one of them is called Sydenham's chorea. This is when you see it, it's very cool and distracting, but it's quite disabling and frightening for the patient, where they have involuntary jerky dancing movements,
Wow.
and they can't control themselves.
Okay.
And it can last a couple of weeks into a couple of months.
Wow. Like
And
a Tourette's style behavior.
exactly,
Wow.
exactly. And it can be very disturbing. So if they had that, or there's some certain characteristic skin lesions that they have on their hands or nodules,
Okay.
those are very pathognomonic of sore throat associated with the strep infection.
Okay.
And so then we recommend that they need to be on secondary prophylaxis. So they get a monthly shot of penicillin, or if they're allergic to penicillin, there's an alternative medication they can take orally. And the recommendation is to take it up to 40 years of age.
A monthly shot until you're
Yeah,
40.
until you're 40. But if you are, for example, you're in a career where you're around school kids, you're a teacher or a nurse,
Mm-hmm.
a doctor, you're working around children, you're working in a children's home, then the recommendation is to take it for the rest of your life until you're out of that environment.
Wow.
I mean, and in Africa and many places in other low to middle income countries where the population is very dense,
Mm-hmm.
cross infection is really high.
Yeah.
So the recommendation would just be to take it for the rest of your life.
Yeah, that's something that I didn't understand until I started getting into the global statistics on a lot of these issues, is just how many people are in Africa compared to, say, Latin America or North America. There's just a lot more people there. So that makes sense that cross contamination, things like that are more of an issue there.
Yeah, I mean, just to put it in perspective, I've had the privilege of training and working in Auckland in New Zealand.
Mm-hmm.
They have an indigenous population, the Maori,
Mm-hmm.
and rheumatic heart disease is still quite prevalent there. It's very surprising.
Mm-hmm.
Now, the population in New Zealand is about 5 million for about 79,000 kilometers square, compared to Kenya, which is 585,000 square kilometers with a population of 50 million.
Mm-hmm.
Yeah. And so where you have dense population, the cross infection is very high.
Yeah.
Yeah.
It's sorry to go back for a second. The 40 million people that are impacted by rheumatic heart disease, is that all across Africa, or that's just Kenya?
No, that's all
That's
across.
all across
Yeah,
sub-Saharan Africa.
like across the world,
Across the
about
world.
40 million,
40
but
million
a
across the
good
world.
number, about 75 to 80% of them are in sub-Saharan Africa.
Yeah. Okay. Okay. I got it. I'm following you now. Wow. Wow.
Yeah.
Um, well, I think that
So when it comes to the question about the 2.5 billion
Yeah.
you know,
Yeah.
being brought to Kenya. We're excited about that. But I personally would hope that the Kenyan government and the Ministry of Health would take a good look at the landscape in Kenya
Mm-hmm.
of healthcare and what are the healthcare needs. And I would hope that cardiovascular healthcare takes a priority in addition to the infectious disease.
Yeah.
Because I feel if we don't address it now, we're already seeing the effects.
Yeah.
It's going to be quite devastating.
And it's very, a patient that doesn't get well is very expensive for the system,
Yes, it is.
right? So it's cheaper to fix somebody's heart. Not only are you saving their life, but even if you're looking at it from a budget perspective, you're saving money fixing them now versus them returning and returning and returning to the ER. Because especially with the congenital heart defect, well, even rheumatic as well. I mean, they pass away, and that's of course there's the humanitarian side that's very sad, and that any kid dying of something that's fixable, is difficult to deal with. But budgetary wise too, they're better off fixing it than letting it go on and on and on.
Yeah, and I mean, if you have a population where a good number of them suffering from the disease don't get to their 20th or 25th birthday, you're also thinking, what is the impact on the generation to come? Who's going to drive the economy?
Mm-hmm.
Yeah. So, I mean, there are bigger, larger scale impacts of all
Well,
of this.
hopefully the folks listening can understand that adding, this cardiology. I mean, in my opinion, Tenwek's new Cardiothoracic Center is globally. I don't know every project going on in the globe, but I think it's probably the most important, specifically in the world of congenital heart defects and rheumatic heart disease, but also in just a rising of healthcare across an entire hospital system, and that like we said, all the infectious disease and everything else that's equally as important. That quality of care and access to care gets improved with the cardiothoracic centers. And to be straight, here in the United States, cardiothoracic centers generate a lot of revenue for the whole hospital system. I don't know the exact margins at each hospital here in the U.S., but those programs, the dollars brought in from those programs can help fund other, research and development and other hospital expansion projects. So I know there's always budget issues, and there's NHIF and all sorts of stuff we can get into on how these things get funded. But my belief is that adding the cardiothoracic units improves healthcare all across the board.
Yeah, and I think the other arm of it is where you have, I mean, I would say Kenya is pretty young with when it comes to having a very robust cardiovascular approach to being able to manage the diseases. I think we're still growing if you compare with, you know, first world countries.
Sure.
I would hope one of the things that they would also consider is looking at how they can invest in empowering and equipping centers of excellence. So where you have, if they can be strategic in seeing how they can invest in centers that are strategically located so that there's good coverage, geographic wise, patients don't have to travel extremely long distance to seek care. The referral systems are well ionized
Mm-hmm.
and well developed so that even if there are fewer centers of excellence, but it's very clear how a doctor out in one, from the northern part of Kenya, which is very arid and difficult, but has patients who need good cardiac care, can be referred to a center of excellence. So looking at those referral systems and networks, and then investing in them, not only equipment wise, not only medication wise, but also human resource wise. And then I think once that's really developed, then you have the strength within the country to be able to replicate those centers over time. To me, I think that would be the best utilization of the resources. And so I think partnering like we have a Kenya Cardiac Society, and working with the Kenya Cardiac Society and the Ministry of Health, in the government to really look strategically where are the areas where we can really help invest, equip, empower, really build and enhance local capacity. And then over the years, after we really developed a strong program, being able to replicate those and, if you will, devolve them into, grassroots level. I think for the long haul, that would make a bigger difference.
That's the solution long
Yeah,
term. Do you
yeah.
consider Tenwek to be one of those?
I think it is. I
Yeah.
think we have proved ourselves at a point where we really didn't have anything. We saw a need, we rose to the challenge, and we've proved that we can be shrewd with resources and be thoughtful and mindful of how we progress into the future. We've proved that we've caught the vision of the importance of maintaining legacy. We've started training programs to make sure that we are not only catering for the generation now, but for future generations. And I think that's the model. That's the only way we can be sustainable. So,
Yeah, I agree.
yeah,
Even the forethought of the apartment complex built onto the
yeah.
back of the new facility so that visiting surgeons and people can come get training there, to go out and continue to build programs other places. It's not just a place where a lot of hearts get fixed, and I want to get into the numbers and what you think is possible there at Tenwek, but it's a place where people can get training, and so great that that was a forethought in the whole project.
Mm-hmm. Yeah,
Wow.
definitely.
Well, what are the numbers at Tenwek? Early 2000s, basically zero people were having, little kids were having pediatric heart surgery.
Yeah.
And how big is the program now?
Yeah, so when we started, we were doing maybe 20. The first year we did 20 cases,
Okay.
open hearts. And from 2008 to 2016, where we relied heavily on fly out mission groups that came
Yes.
for a short duration of time.
How many would come in a year?
We probably would have 3 or 4 groups come.
And they come
Yeah,
for a week or two?
yeah. We would encourage about 2 weeks.
Okay.
And because they would come help do the screening, assess the kids,
Yes.
we run down a list, and it's very difficult where you have 300 patients that show up, and then you have to narrow down to 20 patients.
God, I've heard those stories. That is a job I would not want.
Yeah, that's very difficult and continues to be difficult. And so between 2008 and 2016, over an 8-year period, we did about 310 cases.
Wow.
And then at that point, we were feeling pretty good about ourselves.
Okay.
But then all this data started coming out, globally about how terrible rheumatic heart disease is and how many people are dying. I think global surgery awareness really started catching on to cardiovascular health,
Yes.
and especially in sub-Saharan Africa. And there was a declaration from Cape Town that came out. I mean, it's usually rare. It's difficult to get a publication in a landmark journal.
Okay.
But when one publication is made in 7 different
Oh,
journals,
wow.
that speaks
Okay.
volumes about how significant the issue is. And so they recognize that cardiovascular disease was a major cause of morbidity and mortality, and particularly rheumatic heart disease was a neglected
Sure.
disease. And they say the only way to help beginning to make a dent in dealing with it was to train, and particularly train surgeons and
Yep.
perfusionists, because we had to deal with the structural devastation we were seeing, as we also concurrently deal with primary preventative health strategies to try and manage and hopefully eradicate rheumatic fever.
Yeah.
Yeah. And so all this data is coming out. We're feeling pretty good about ourselves, and we felt like we were doing nothing.
Really?
Like our impact was just a drop in the bucket. And so
And this was before the center was
this is
complete.
before the center was
This is
built.
what you were
This is in
doing
2016.
in
Yeah. So
with the regular general hospital.
yeah.
Yeah.
So a lot of fly in, fly out missions. And
Yeah.
then that's when it really hit us. We've been doing this for 8 years. We've just done 310 cases. We have 700 patients on the waiting list, 500 rheumatic and, coronary and others, and 250 congenital. And every week, 5 to 7 patients die on the waiting list.
Yeah.
Every week.
Every week.
And so we thought we have to do something more locally, as a country, as
Yeah.
an institution. And so then we started having a focus on, it's just not fly in, fly out, but how can we build local capacity? How can we start training local people to take on the job.
Yeah.
And so that's when we started. We had a strategy and started doing low risk cases, single valves, very straightforward congenital cases, going back and forth with our partners back in the US and Canada. And so we started seeing an increase in the number of cases that the local team was doing.
Mm-hmm.
And then in 2018, we started a fellowship program that myself and Dr. Rega, my colleague, we were the first general surgery
Nice.
residents.
Homegrown.
And then we became one of the first two fellows that graduated from the fellowship. Those are perfusionists from the US, Bob Groom. He's been a clinical perfusionist with experience in over 30 years. Really
Okay.
great guy. Started a perfusion program.
Okay.
And actually one of its kind. And he got a very fancy simulator that they use, and you get a real deal experience. You feel like you're in the driver's seat, similar to
Wow.
what the pilots used to
Wow.
train in the cockpit.
Wow.
Very impressive. And so they've been able to train perfusionists, and we've been able to train 5 cardiothoracic surgeons out of our program as of last year. And we have 6 in training,
Yeah.
and actually added 3 more in training this year. So the programs are growing, and we started critical care nurse training in conjunction with the Tenwek School of Nursing. And hopefully we'll start a cardiac critical care nurse training.
And are these specific for Tenwek, or people from other hospitals can come get training? And
This is open to
this is open to
anyone,
anybody.
yeah,
That's
because
incredible.
we believe in empowering everyone. Yeah.
Wow.
But so it was part of the thing of developing the workforce, and because we felt the only way we can make a bigger impact is if we start really building local capacity.
Yeah.
And so as we were doing all this, we outgrew the space, because we were doing all these surgeries in only one operating room,
Right.
and we had access to the room 4 days out of 5.
Yeah.
We had a small ICU with 7 beds and a step-down unit with 7 beds, but
Okay.
this catered for all the other specialties: internal medicine,
Yeah.
obstetrics, pediatrics, surgery, and surgery and trauma
Everybody
is huge.
needs more space.
Everyone needs more space, and cardiac surgery postoperative care is labor intensive. We didn't have the full complement of intensivists and cardiologists and critical care nurses. So I mean, these are good growing pains that we went through when you start a vibrant cardiac surgical program in a rural-based mission hospital. We went through all that, and it was good growing pains.
Yeah.
But so that's where the need of developing a standalone unit came from, because we say that the need is so huge, and there is so much that we need to do. And that's how the Cardiothoracic Center was born.
And I'd imagine I've heard Russ talk a little bit about, and we should note that Tenwek is a mission hospital. So I think the slogan is, what is it? It's
We treat and Jesus heals.
We treat and Jesus heals, right?
Yeah.
So I know that Russ was having a lot of conversations with God on, things are being laid on his heart. And I can imagine the thought of building a giant cardiothoracic center and where you're going to get the funding for that was like, I don't know, the Columbus trying to find America or something.
Yeah.
That was a pretty big dream and a pretty big vision.
Yeah.
And one of the stories I heard, and a big shout out to Samaritan's Purse that funded the lion's share of that project. And I'm probably going to mess this part of the story up a little bit. You can fill in the blanks, and the dollars are probably off too. But I remember him saying that I think he received a late night phone call one night from Franklin Graham, I believe
Yeah.
it was, from Samaritan's Purse, and said, "Congratulations, Russ. Our board has decided to fund, $3 million of your project." And Russ said, "Oh, great. Thank you so much. That's going to go such a long way." And it was maybe the middle of the night, or time was different or something. And then,
Yeah.
and then Dr. Grant says, "No, Russ, I don't think you heard me right. At $30 million of the funding." And Russ went, "Whoa, okay, now I'm awake,
Yeah.
So I
Yeah.
probably messed up some of those details, but, just what an incredible blessing for all the people there, and props to Samaritan's Purse for doing it. They're so impressive. I was visiting with some folks at the M3 conference this weekend from Samaritan's Purse, and everything they do, from their disaster relief to their heart program, I mean, they are really out there doing the real work.
Yeah,
It's pretty
yeah,
neat.
yeah. They go full at it and they really invest. It's amazing what they're doing for the kingdom. And yeah, I think sometimes um it's like standing up on a mountain and looking over to the horizon and thinking, you have this great vision or great dream that God lays on your heart and you're thinking, how am I going to achieve it? But it's very humbling because it reminds us it's not about us. And he brings all these people, just like the way he provided the sheep when Abraham was going to sacrifice his son. He just needed to see dedication and someone being willing to lay down everything. Um, and he provides it. He owns the cattle on 1,000 hills. So he just brings all these people at the right time. We got people, Samaritans Pass, to help with the building, which was great. We got a company that was willing to provide all the furniture for the building, OFS. We got HFG, a brilliant architectural firm that works here in the US that has worked on designing hospitals. They wanted to partner with us. I mean, it's just amazing the people that God brought along to
Yeah,
make
what's
this
it been like
happen.
for you as a front row seat?
Oh man, I am blown away. I think sometimes I pinch myself and I'm like, this is a dream. Like it's not possible. It's such a privilege to be able to witness it all. That's all I can say. It's a huge privilege and blessing.
Yeah,
And therefore, like, you know, when people think, why do you do what you do? I say, why not?
yeah.
Why not? Like,
What else could I be doing
yeah,
that's cooler than this?
yeah. It's such a privilege. Such a privilege.
Unbelievable. Well,
Yeah.
I think the of the 2.5 billion, if 50 million is what it costs to build, the cardiothoracic center there at Tenwek, you could build five of those for 10% of that
Yeah.
2.5 billion. To your point, I don't know the exact numbers to build five of them or 10 of them, but if you spent 10 to 20% of that budget on building these centers of excellence, like you're talking about, I think you drastically improve healthcare across all of Kenya specifically, but if you do it in the way that you guys have done it there at Tenwek, that's going to impact all of sub-Saharan Africa. I know you've got kids coming in from Somalia and Tanzania and
Mm-hmm.
other places that you treat, so
Mm-hmm.
it's not just limited to Kenya. It's the
Yeah.
entire region.
So far in the last year, definitely, and over the years, we've treated patients from 14 different countries.
Unbelievable.
Yeah.
I might come there if I have something going on, man. It's
Yeah,
really
we'll give
nice.
you the best care. Give you the best care. We always joke, Dr. Ras has a joke he always tells patients. He's like, I'm gonna look in there and I'll see if I find Jesus.
Oh, that's funny.
Yeah. In one of the chambers, if Jesus has taken residence there. And
That's
if he
funny.
hasn't, we'll talk about Jesus.
That's cool.
Yeah.
Well,
Yeah.
I just have a kind of a nerdy question about CHD surgery versus RHD
Yeah.
surgery.
Yeah.
In general, which ones are easier cases?
I would say it's a spectrum.
Okay.
Um, if you catch rheumatic heart disease early,
Yep.
before the heart function, like the heart muscle and its ability to tolerate the heart failure effect is compromised,
Mm-hmm.
the patients generally tend to do well. Um, the problem though is if they get recurrent attacks of rheumatic fever, the remaining native valves may get affected.
Okay.
The challenge though is we see a lot of patients coming very late and even efforts in trying to repair the valves so that they keep their native valves and avoid the complications that come with the blood thinning medications,
Okay.
that can be quite devastating. It's difficult to achieve that because they present late. So if caught early, it would be easier to deal with the rheumatic heart disease.
Okay.
Now, when you look at congenital heart disease, it's difficult to just give a blanket
Right.
statement because they're a spectrum.
Sure.
You have simple congenital heart diseases like the atrial septal, ventricular septal. So these are holes in the upper or the lower dividing walls between the chambers.
Yes.
And then you have some patients that have a persistent of the extra vessels between the two large vessels that come out of the heart. What's the PDA?
Yeah.
This in the Western world are easily fixed where interventional catheter-based device, so you don't have
Yeah.
to have
You can
open
just
heart
do it through the
surgery.
cath lab.
Yeah, unfortunately, because of, again, lack of awareness of congenital diseases in Kenya and
Yeah.
lack of screening exercises, um, a lot of children who are born with these defects that could be easily fixed before the first year of life, if they're symptomatic,
Yes.
or before their fourth or fifth birthday, preschool age, they present much later when there are a lot of other secondary effects, either around the heart or around the lungs,
Yeah.
and they complicate the simple surgeries. And then, other than those simple defects, then you have a spectrum of more complicated congenital heart diseases. And these are not only one time surgery, they may need multiple surgeries to fix them
Yeah.
over their early childhood or into their
Yeah.
adulthood. Yeah. So I would say it's not
It's not. Yeah.
a straight answer.
They're both
Yeah.
difficult.
They're both
And every now and
difficult to
again, you get
manage.
some easy cases.
Yeah. Yeah.
Wow. And sorry, back to the numbers. So how big is the program now? How many kids what did y'all treat last year, or are you projected to treat this year?
Yeah. So we did 450 cases, total of cardiovascular and thoracic. Pump cases were about 350.
Wow.
Yeah. And about 60 to 65% of those were non-congenital cases.
Wow.
So rheumatic cases and other from valve lesion and valve lesions from other diseases.
Wow.
We are hoping to increase the number for congenital cases. I think one of the big limiting factors is the awareness and patients coming for healthcare early enough when the lesions have not caused significant secondary effects.
Okay.
Because if, for example, you come with just a simple hole in the heart, but it's been long standing and now you have significant hypertension in the vessels of the lungs, it's too dangerous to operate. Then
Yes.
we leave you to leave out the natural cause of the disease.
Yeah.
Yeah. So early detection. The other big challenge with congenital heart disease is the intricate intraoperative repair for some, and also anesthesia and perfusion support.
So it's extremely complicated.
It can be complicated. And then the last bit is also the post-operative care.
Yeah.
And the follow-up is a little bit more rigorous than just straightforward valve replacement
You need
surgery.
a pretty sophisticated ICU with
Yeah.
ICU doctors and
Yeah.
nurses for the
Yeah.
step down.
Yeah.
Yeah.
Yeah. And then the post-operative long-term follow-up also
Yeah.
is more labor intensive.
Yeah.
So those are the things that make congenital heart disease a little bit more challenging in addressing rather than the valves.
And you might, I can imagine, operating on a small baby or a 1-year-old, and I mean, you're talking about a heart the size of a bottle cap or
Exactly.
a walnut or
Yeah.
and then as someone that might have it as a child, a few years go by and they're an adult, so like you said, it's sort of a lifelong follow-up treatment.
Yeah. And I think that's one of the things maybe I would put as a caution. For a long time, it's been thrown out that certain lesions are one-time fix. It's a one-stop shop. Like you go in, you get your whole fix, and it's done. But it depends on at what point it was caught and if there are already secondary effects that were happening. As a child grows, sometimes there's a lot of materials we put in, patches, conduits, and things to reroute, abnormal blood vessels and things to fix leaky valves. Sometimes the repair, depending on how advanced the disease is, may not be 100%. They may need revision surgeries in future.
Yeah.
They may need upsizing of conduits or pipes that are put so that it matches up with your body surface area and your weight. And so it's important as we try and address these lesions, especially to the parents, especially to policymakers in health, to understand some of these lesions is not a one-stop
It's not a
fix.
one and done. Yeah.
And then also how we care for the children as they transition into adult life.
Yeah.
I think it's an area where we really need to think how we invest in that. I think it's a forgotten need.
Because a lot of people want to help children.
Exactly.
And that's a great mission. A lot of people should help children, but those children after a few years become adults.
Well, they'll become adults and they struggle. And it's not just, there's a lot of research that goes into what is the effects of anesthesia on these children when they have extensive surgeries. You're under anesthesia for long hours. You're on the ventilator for long hours. You're on all these medications. what is the effect of that on development,
Yeah.
mental or otherwise.
Brain, everything. Yeah.
Yeah, exactly. And their impact in school. So these are things that I think we have forgotten to
Okay.
take into consideration.
Yeah.
And having had the advantage of training in the Western world, I have seen that there's been a lot of investment put in helping children transition through teenagehood into adulthood.
Yeah.
And then there are long-term consequences where they may need further revision surgeries when they're adults. They're more prone to infections around the heart, around the valves, endocarditis, and then also for females, when they get into a point where they want to have children, how do we manage their obstetric career? How do we advise them?
Because putting the heart under the stress of carrying a child
Exactly.
can be problematic as well.
Exactly.
Yeah.
Yeah. So there is a huge bit of congenital heart disease care that I think doing the surgery is great, but in about 10, 15 years, you start getting a new subset of problems that needs to be addressed.
Yeah, and we should note, like we talked about with rheumatic, that comes from strep throat. Congenital is something that around 1% of the population is born with, and
Yeah.
that at this time, there nobody knows if it is preventable. It's currently not, and this impacts 1% of people. Doesn't matter where you're born, what country, what planet. 1% of humans have congenital heart
Yeah.
defects that need repair.
And I think for me, I say this, it's been a privilege. My training was a little bit off. I did, something a little unusual. I did general surgery and then I did pediatric surgery and did cardiac surgery with an interest and a focus in pediatric congenital. And some people have told me that's a little bit much, but I think God allowed me to do that for a reason, honestly, because my dream has always been to practice in sub-Saharan Africa and other underserved populations.
Yes.
Congenital diseases tend to run in pairs or in threes. So you'll find someone has a heart defect, but they also have something else with another system in the
Okay.
body. And there are many times where the focus is on one system and the other system is forgotten, and it
Okay.
affects the whole person.
Okay.
So for me, I think my training it's given me an upper hand, and it's a privilege to be able to see that and be able to address the whole patient, and then advise the caregiver or the parent or guardian how they can really take care of the patient and help them make good decisions on how to manage that. But yeah, I think it's really important to remember that, I was always taught, one of my good mentors, Mike Liskey, always says, Agneta, the commonly missed defect is the second one, because you're so focused on the first one, you miss the second one and you don't address it. And it has a bearing on how you do with the first
And your
defect.
training has given you
Yeah.
access to see those
Yeah.
versus someone that maybe just went directly into it.
Yeah. So I think I know there are many trained people in individual fields, but
Sure.
for me, I think especially where I work and my desire to be in sub-Saharan Africa and other underserved areas, I think it's given me an advantage, and it helps me see other things that I may have not seen if I just did one field. Yeah.
And how big do you think the program at Tenwek could get? How many patients do you think it could serve?
So we've done 310 in 8 years. When we first opened the center,
Yeah.
in the past year we've done 300 open hearts. So we've
Yes.
done
What you
what we
did?
did in a decade, we've done in 1 year.
Yeah.
But 450 total. And I think we probably, when we're full, so we opened it in a phased approach. So we
Okay.
only opened 1/3. So started with 2 operating theaters and a cath lab, but we have 5 operating theaters, a hybrid theater, and a cath lab. And when we're fully operational, we could easily be doing 2,000 to 2,500 or 3,000 cases open hearts a year. So I mean that would be huge.
That would be huge. I mean, that would
Yeah.
rival. I mean, are there bigger programs than that in the world? I mean, that's pretty big.
Yeah, it's big.
It's really big.
Yeah, there will rival programs in the US or
Yeah.
Yeah.
Yeah. I know India's got some really big
Yeah.
programs as well.
yeah.
That's incredible. And what do you need between now and then? What resources, what people, what do you need to get there?
Yeah, so I think the reason we did the phased approach is getting the big thing was human resource. So
Okay.
getting a full complement of specialists, cardiologists, adult and pediatric, anesthesiologists, perfusionists, nursing is a huge thing. I think, doctors are great, but I always say nurses are the ones who drive the boat. They run the world.
Yeah.
And so getting critical care nurses are important, and nurses in the outpatient clinics, outreach clinics,
And it takes time to train
it
all
takes
those
time to
people.
train them and to train them well, especially the more specialized any field is, the longer the training for each of those. The lead time to training for each of those specialties I've mentioned is longer and more intense. Um, yeah, so human resource is one factor, and then the other one is equipment.
Okay.
Yeah, it's you need a lot of expensive dedicated equipment to do that well. So the heart lung machines, the cardiology equipment, the equipment and the supplies used in the cath lab, for example, to do interventional procedures, and not only the interventional things that we do are also for diagnostics, because sometimes you need to do certain things and anesthesia to find the patient has this type of congenital heart lesion, but they've had it for so long. What are the effects in the lungs, in the other organs, and can we safely proceed? So those include the diagnostics that you need to do, and the supplies for those are very expensive as well.
Yeah.
Yeah.
Okay, so let me slow down a second. So back to the people. Is there how to get those people? Is there an opportunity for people to apply for training or for a career there at Tenwek, or how do you, or do you just look at it like, okay, this is phase one, we need these people, let's get them trained, and then for phase two and phase three, we need to hire,
So the way we approached it is, for the human resource, you can split them into different categories. You can source for those who are already trained, part of the program, the likes of myself, Dr. Rega, who are trained on the program and who are committed to joining the program and helping build it. And then you have the ones who are already in a training stream that you empower, commit, bond to. Once they finish the training, then they'll be able to join the pool of the workforce. And then there are those who are trained elsewhere, and you can, and this is why M3 is really cool, because then you can reach out to them and encourage them to join what you're doing.
yeah,
And then you can also go to medical schools
yeah,
and hopefully share the vision and encourage them and say, if you're going to a training program, either outside or if it's available within the Tenwek training fellowships
yes,
or residencies that are available, if you commit with us, then you can come and work. And then there's a volunteer group of people that you reach out to come.
okay.
So it's just, I think our approach has been to have a multifaceted way that we approach and attack the whole thing.
And are y'all still having groups come in and do
Yes,
how
definitely.
what's the goal? Is it one a
So the
month or?
goal, now that we are able to have housing available and we have the space and the rooms to accommodate them, we usually have maybe a visiting cardiac surgeon, maybe once every, sometimes every 2 weeks to
Oh,
6 weeks.
wow,
Yeah.
that frequent.
Yeah. So there's a lot of interest.
Wow.
And it's good because they're also coming and they join the teaching programs.
Yeah.
Yeah. And then for the big teams,
So
we
they
have
help
about,
teach a little bit
they
while they're
help
there?
teach. Yes.
That's great.
Yeah, we have a pool of international faculty that have committed. They wake up, it doesn't matter the time zone. We just set up a time zone that's convenient to as many people as possible and
Unbelievable.
they sign up. And every week there's
On
didactics
a
and,
Zoom call.
yep.
Isn't that so great?
Yeah, it's
We've
amazing. I
experienced some
mean,
of that
I
too.
think it's such a rich culture of medical training that we get there. It's unbelievable. And then for the teams, we create, we call them camps, like surgical camps, but the emphasis is more transferring skills for the more complex cases.
Okay.
Yeah, so like the more complex congenital type cases where you need more additional technical support in the operating room. And again, the emphasis is still transfer of skill and local capacity building.
Yeah.
And you need additional maybe like critical care nurses that come to help support the local nurses that are there, just because like the post-operative care could be even more labor intensive. So then we still allow for the camps to come, and we do about 4 or 5 camps, if you will, a year where we have those more specialized teams that come.
So the training camps and then the folks. So you've got a pretty good revolving door of
Yes.
teams coming in
Yes.
to do a lot of those
Yeah.
cases.
I think one of the area where we really need more support are like the intensivists and the cardiologists. We have a good pool. Um, in fact, the cardiologists and the radiologists have developed a team that are available on standby online to help
Wow.
with,
God, that's
being able
incredible.
to read the data and interpret and help give support to
That's really
help with
neat.
care. Yeah.
And then plus, and you're in New Zealand right now. How much longer are you in New Zealand?
I have 3 more months.
3 more months, and
Yeah.
then once you come back,
Yeah.
that'll somebody that'll be.
Yeah.
How many cases will you do in a week or
It depends on how many rooms I want to give me.
right?
Yeah. But also, I mean, you have to balance that with the support. Like,
Sure,
again,
sure.
I keep going back to it because I think it's so important. You can have the best center, honestly, you can have the best equipment, but I think the thing that really drives is the human resource aspect.
Okay,
Yeah. I mean, I can say surgery is one thing, and especially cardiac surgery, that emphasizes the importance of team sport.
okay,
Yeah.
okay.
Yeah. It's
Cool.
not a one man or a one woman show.
Got it. So you can be the best surgeon in the world, but
Yeah.
you
If
need
you
a
don't have a
giant team around
team,
you.
yeah.
Okay, got it. Well, you seem
Yeah.
like a pretty good team builder as well as a good surgeon, so that gives us hope. Those of us in the stands rooting for you,
I hope so. I've had good mentors, and I've gotten to where I am because there was a whole team that supported me, and my goal is to pay it forward.
right?
Yeah, and I'm all about building the team and encouraging. I think everyone on the team has a voice,
Yeah,
and they need to feel that they're in a safe space where they can contribute. And yeah, when there's a good outcome, we all celebrate. When there is a sad outcome, because I mean, to be honest, this is a difficult field we deal with.
yeah.
Our goal is to help and build, and there are times where we have difficult cases and the outcomes may not be as we want, but we want that everyone experiences that, everyone owns it, and no matter the outcome, that we accompany the patient, the guardians on that journey, and the staff and support them.
Yeah.
Yeah.
Wow. And back to the equipment. You have a pretty good network of people that can get y'all equipment or help fund new equipment when you need it to scale up.
Yeah, I think we have a resourceful group of people that we can, touch base with. They're like our sounding board. And
Yeah.
so if we need to buy, for example, new echocardiography machines, the pool of cardiologists will say, based on the market and where you are and what you need, this is the best equipment. And we have places where we can do benchmarking and make sure that we get the good equipment. I think the big thing is just getting the funds
Getting the
to,
funds.
yeah, to get the equipment.
And if people want to help fund equipment, how do they do that? Do they go online and donate or?
Yeah, we have an online portal.
Yeah.
And one of the, in our departments, we have a strategy and projects department that
Okay.
helps, we run through them and, forecast vision and see what the needs are in the hospital. And then, yeah, we can advise donors or well wishers where they can send the funds to.
Yeah, I think that's important for fundraising. If you say, "Hey, we need a new heart and lung machine and it costs X," and the result of that is, another 200 kids are going to get heart
Yeah.
surgery this next year.
Yeah.
That's fun for somebody that likes to fund projects to be
Yeah.
able to identify with.
Yeah. Yeah. So I think that's a need. And then just the aftercare program, as I mentioned, for the postoperative patients
Yeah.
is another area. As much as we have the Social Health Authority Fund, the SHA, and the monies that, with this hopefully partnership with US
Yeah.
will yield good results, we really need to think strategically how we can generate funds that we can be self-sustaining to help, because we always constantly have a pool of patients who are so needy.
Yeah.
A lot of people still live under the poverty line.
Oh, for sure.
Yeah. And so we need to think about them. As I mentioned, it's a very expensive enterprise to do cardiac surgery, but I think to me it would be so devastating to be able to do the surgery and someone dies in 6 months because they weren't able to get transport to come for testing, to make sure their blood thinners are working well, or make sure they're on their anti-failure medications. To me, that would be a tragedy.
That's a bad outcome. Yeah.
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 Yeah. So we need to find a way to empower people to own their health, but also to help them journey as they deal with all their other things they deal with in life, because it's not
Yeah.
only cardiac disease that they're dealing with, there are other struggles and challenges, unfortunately, that we're dealing with.
Well, when I look at projects around the world that are in the CHD space, going from 400 something cases to 2,500 cases, that's an extra 2,000 kids a year. For me, Tenwek seems like if I was a betting man, that's the place to place your bet. And out of any project I've seen, there might be some other really great ones out there, but as far as the team building, the capacity, the training, the number of kids being served, it's just such a great opportunity if people want to help to jump in and help out there. Are there any other needs that Tenwek will have in just the city of Bomet? I've never been to Bomet before, but I've looked at it on Google Earth and I've talked to my friends that have been there. And are there anything, just housing or schooling or
Yeah,
restaurants or?
I think one of the reasons we have struggled with getting expertise support, like,
Yes.
I mean, we have cardiologists out and intensivists, but I think the reason why they don't come out into Bomet, which is like considered rural southwestern Kenya, is just other availability of other amenities
Okay.
that make life bearable.
Creature comforts.
Yeah, unfortunately, we're human and we yearn for those things.
Yeah.
So schools are very important.
Sure.
So we have a very vibrant group of professionals who have families and want to send their kids to good schools. So good schools around there are a challenge.
Okay.
And then just other amenities around there, like, recreational facilities, parks.
A martial arts gym.
Yeah, exactly. I mean, and it's amazing to see, like, we have a general surgery residency program and orthopedic residency program, and actually there's a gym that was recently created and it's one of the residents who started
Oh,
it
cool.
because there is a need. So those things they look simple, but they actually do matter, and
Yeah.
they help, because we have to think about, I was joking with someone, we are not calling it work-life balance now, because work is part of life. We are now
Okay.
going to call it life balance.
Oh, I love
Yeah,
that.
we have to think about
I'm
life
writing that one
balance.
down.
Yeah.
Life balance.
Yeah. Keith and Linda we were talking, and yeah, we have to now think about life balance, and soul care. And yeah, so I
Yeah.
think all those things that make it attractive to be
Okay.
able to work in such a place,
Okay.
that you may be far away from family or
Yeah.
friends, but
Yeah, because
yeah,
it is in the middle of
it's
nowhere
in the middle of
in
nowhere.
Bomet, which is
Yeah.
beautiful. But having access and things to do while you're training there
Or working
or
there.
working there is important. Raising a family there,
Yeah.
all those things. So,
Yeah.
okay, so if there's maybe an entrepreneur, like a for-profit person listening to this, that might be a real estate person or in an infrastructure, whether it's somebody that knows about power grids or water or roads or restaurants or hotels? Is there
Yeah.
room for
Yeah.
investors to come in
Yeah.
and
Yeah.
help?
So we're not only looking at medical people for volunteers. Such people with such skills are really welcome. Because we have to think about housing
Mm-hmm.
for the staff and
Mm-hmm.
for the visitors and volunteers that come. You have to think about, we want to be a hub in sub-Saharan Africa. We're already seeing patients from 14 countries. These patients come with their relatives and family. Where do they stay when they come? So, we've thought about like the Ronald McDonald House model.
Sure.
Yeah, where they can have a place where they stay that's comfortable. I'm very passionate about children, obviously, and I think a key part of recovery from surgery and ailments is just having a good place. So having a good center where the kids can, other than things, coloring. Some kids stay in the hospital for several days, weeks,
Mm-hmm.
some even months, depending on the condition.
Sure.
They may need to be nearby. They may have traveled from another country, but we recommend they stay at least for 6 weeks for their checkups
Yeah.
before they travel back.
Yeah.
Some, depending on the condition, they may be there for 2 months. They need to have some sort of education or schooling or something. It may be informal, but they need to be engaged. A good playroom.
Yeah.
There is a lot that can be done for
There's a
them.
lot that can be done in that
Yeah.
side of it.
Yeah.
And Bomet I know the hospital is a big reason for our big draw to Bomet. What's the rest of it? Is it agricultural, tea,
Yeah,
or
it's mostly agricultural
yeah?
based. Yeah. Yeah.
And okay, it's agricultural
Yeah.
community with an incredible hospital.
Yeah.
If
Yeah.
you build it, they will come.
They will come. Yeah.
Okay, got it. And so there's room now for any, for-profit type investors or nonprofit type investors that want to go in there and help with a Ronald McDonald type
Yeah.
house
Yeah.
or
And partner with the community. There's a lot in the community they can do because I think, as we mentioned earlier, the goal is just not to build an excellent center, but also really to raise the whole community,
yeah.
you know, and um, I think just really see an improvement in care, you know, all around. Like hopefully the other health centers within Bomet County or even in the country, the whole country will catch that and really elevate the excellence of
Yeah.
care that's offered
Yeah.
and build the surrounding community.
I love
Yeah.
that.
Yeah.
Well, why don't we take a quick break and then come right back?
All right.
Okay.
Thank you.
Okay, so teamwork makes the dream work is what they say. Where do you see the power in teamwork in what areas and all these things you're up to?
Yeah. So um I think doing surgery and especially cardiac surgery taught me that teamwork is really important.
Okay.
Um, you can have the best patient that you select for the surgery, but if all the members on the team are not speaking to each other and don't agree on what they want to do, then you may not have the outcome that you desire. And I think it's really important to recognize that everyone has something important that they bring to the table. Everyone is an expert in their field, and allowing them that space to be able to do that, making them feel empowered to do what they feel is their field is important. And then being able to communicate with each other. One of the things that we really model in heart surgery is called closed loop communication. So I may give a direction on what we're going to do. And if it's to the anesthetist, then he gives back feedback. He gives, I might say, for example, I think the best person maybe would be a perfusionist, the
Okay.
person who runs a heart lung machine. I
Okay.
would say, like, take your flows down. That means I need to have a more bloodless field.
Okay.
And then he gives back, he does something on the machine and he goes back and says, flows are now down. And I say, thank you. So that's
So
called closed loop communication.
okay, got it.
Yeah. So you give, I don't want to use the term command because that sounds very demanding, but you give an instruction
Yes.
and the person hears, does it, and gives back
That it's been completed.
that it's been completed, the task has been completed.
Okay.
And that's called closed loop. So that's really important because then everyone is aware what is happening and we hold each other accountable. And at the end of the day, we have a good outcome.
Okay.
So I think teamwork amongst the team members or different people, different specialities when the conduct of surgery is going on is really important. But then now that translates across disciplines, when you move from the operating room to the recovery room, in the clinics where you're doing outreach or ministry, the teamwork flow continues to translate. But then you also think about teamwork with partners or donors. There is a lot that we've been able to achieve because we work with different people who have caught on to the vision and the dream that we have and desire to be part of the good change that is coming out
Yeah.
and the difference that they're making in people's lives. And so we may not be able to provide a certain for example, we may not be able to provide care because we lack certain equipment and someone comes out and say, I'll help and fund to buy the equipment. Or someone comes out and say, I'll help and cover 80% of the patient's fees if they can be able to raise 20% of the fees.
Okay.
And so that's how we are able to achieve something good, even if we ourselves are not able to fund it on our own, but we have partners that work with us, like Heart Gift, Care
Yeah.
for a Child Heart. And then I think on a broader scope, we are in a geographical location for a reason. We ascribe to a county government governor. We ascribe to a country and a leader. and we have to work within the frameworks of the healthcare system. And I think the only way we can really make a difference is if we have good relationships and partnerships with the governments, whether the local governments, the county government, or the national government, and them having a buy-in in what we do. For example, in Bomet as Tenwek, and seeing how it impacts the country, how it has grown the county, and then the relationships that we develop and the medical tourism that we build with other countries around us, and the benefits that then the country develops. That's really important. So I think teamwork goes a long way.
Wow, that's a lot of areas. Kind of back to the medical community there in Kenya. Is it pretty cohesive? I know Russ is. I'm not that familiar with all the structures, but he's the chairman of this, the chairman of that. It seems like he has some level of influence there, and you do as well. And in the country, can you share a little bit about that?
Yeah, I think it's really important to learn that even if we're gifted in certain areas, that we can't work in isolation, and pulling in resources and leveraging with other people that have a similar mind and are able to influence in a good way is really important. And so, yes, Russ White, the CEO of the hospital, and other leaders within the hospital leadership, the board of members, are very intentional about building relationships with different peoples within the healthcare fraternity. So we really like to be involved with the Kenya Cardiac Society, for example, for us that deal with cardiovascular health. We're really intentional about seeking the Minister of Health. We've had times, actually, when the Cardiothoracic Center was being opened, the president of Kenya came and
Yeah, I
was an
saw that.
invited guest,
Yeah.
just to show them that we really do value their input. It's a privilege to work with them, and we, at a national level, would really want them to be involved in helping propagate what is our mission, but really ultimately to see healthcare improve in Kenya and the surrounding environments.
Yeah.
So we're really intentional about building those
Yeah,
relationships.
yeah,
Yeah.
because like you said, y'all could be a subject matter expert in some of that for the rest of the nation.
Yeah.
Wow, that's pretty neat. So, circling back, one last thought on if somebody hears this that's maybe a nurse or a doctor or a perfusionist, and they want to help out, are there opportunities for them to come? Do they need to join one of the dozen or 2 dozen teams that come to y'all every year, or how could somebody get involved?
So we have on our website, if you join there, if you look up AGC Tenwek Cardiothoracic Center online.
Okay.
On our website, we have a place where we invite volunteers or people to join. So you can either come in through a sending organization, or you have opportunity to come as a standalone person.
Yeah.
And someone will reach out to you once you link on the website and be able to give you advice on what you need to join. We usually recommend probably the minimum duration to come is 2 weeks. 1 week is too short. You
Yeah.
barely get there, you're learning the ropes, the system,
Sure.
everything, and then you're leaving. So I think 2 weeks minimum is good. It's important for us to try and balance like the different teams and personnel and people that come, so that we make sure you don't have too many people at one time and it's not overwhelming.
Yeah.
But then that way you're coming to give is a blessing to us, but also your experience is good and a blessing to you.
Yeah.
Yeah.
And they can carve out a day or two to go see some wildlife or
Yeah, there
something
is a
cool.
lot to see outside of the hospital. And there is a lot that they can do also in the community and be involved. Because I think it's really what we do, really, we are at the heart of people. The reason we do this is because of people. And just being able to see the surrounding environment and how people live, and being able to experience the daily challenges that they have and see the impact of what they're coming to do, how that really impacts the community around them. It will give them an idea of how it impacts the larger community. I think it's really important.
Yeah.
Yeah,
That's neat.
yeah.
Okay. Well, Dr. Agneta Odera, really appreciate you coming in and spending the time with us here. You are a force to be reckoned. Excuse me, I have a quote from an article in Forbes magazine. I don't want to embarrass you too much, but it says, Agneta is a genius and a force of nature. She is ushering a new era of healthcare in sub-Saharan Africa that's female-led and holistic in its approach. And I found that to be true through this interview and through following your work over these last few years. So just really appreciate everything you're doing for the world, for the kiddos in Kenya, for the kiddos in the world. Appreciate your participation in the M3 conference here, which is where I got to meet you, which is a really neat story. Because I attended a conference here a few years ago that Lakewood Church puts on with Dr. Paul Osteen, that connects people that want to get involved in missionary type work, in medical missions. And I saw Russ give a speech, and I met a guy named Solomon there. Solomon is a mutual friend of ours that runs an organization called Care for a Child's Heart that helps get kids to you guys to have surgery. And because of that relationship, there's been at least a couple, 200 to 300 kids have able to received care at Tenwek and a few other hospitals there in Kenya. And it's just been really neat. Back to the teamwork theme of Heart Gift and Care for a Child's Heart and Tenwek and all the work you're doing. And it's really inspiring to see you. I mean, you've already had a major impact, and you're just sort of now coming online here in the next 3 months as you get back to Tenwek. Is like, man, I'm really excited to have this conversation again in a year or two and see how much bigger and better you've grown the program, and hopefully some folks listening will earmark some dollars to even folks like our friends that we were connected with at the Gates Foundation, last week. I mean, they're sunsetting. They're deploying, I think it's 70 something billion dollars over the next 20 years that they want in global health.
Mm-hmm.
And that's a lot of, you take 1 billion of that. How many Tenwicks can you build with that, across the world?
Mm-hmm.
And back to our point of this whole thing is, that what you guys have done at Tenwek is a model for the rest of the world to follow to increase the quality of healthcare across a lot of different areas. So
Yeah.
thanks for leading the charge in that department.
Well, thank you. I think it's, I say this, if there's any greatness that people see in me, it's because someone believed in me and encouraged me and challenged me, and gave opportunity, and I want to pay it forward. And so, and this is about us just really listening to what God is calling us to do. I love my work. I'm passionate about surgery, but for me, honestly, what I do, I believe, is a calling that God put on my life, and it's something I'm not ashamed to share about. And I think I can end by saying one of the, actually, the last commission that Jesus gave his disciples before he began his journey on the cross was, he told them, "Greater things you will do than these things you have seen me do,
Wow.
because you believe in me, and because I have shown you the Father." And we do these things because, for me, it's what God has called us to do, and apart from him, we can do nothing. And I think there is so much heartache around us, and sometimes when we look at these numbers and the statistics, it seems overwhelming. But I want to challenge us not to see it as a burden. Let us see it as a privilege, an opportunity to partner with him. And for those who are thinking, how can I join? How can I contribute? What can I do? Just dare to have bold faith and step out into what God is calling you to do, and how he may be speaking to your heart to join this. And if you seek him honestly, he will show you how to do it, and make a way. So, yeah, I think there is so much that we can do to give healing and hope and restoration to a very hurting world. And for us, we can do this together. So thank you for the opportunity, and I look forward to doing this with so many more people.
Wow. That's beautiful. Thanks for that.
Thank
All
you.
right, everybody. Bye, guys.
Thank you.